Hi guys, today we'll talk about arterial blood pressure. So, what is arterial blood pressure and what is pulse pressure and what is mean arterial pressure? We'll talk about that, and we'll also talk about that what are the factors that are affecting the arterial blood pressure, and we'll talk about regulation of blood pressure. So, first we'll go. What is blood pressure? So, if we take this blood vessel, the blood in this has two entities. One is the lateral pressure and one is the end pressure. So our concern is this lateral pressure. So blood pressure is nothing but it is a lateral pressure exerted by the column of blood on the arterial wall. Systolic blood pressure and diastolic blood pressure are the two entities. So what is systolic blood pressure? It is the maximum blood pressure in a cardiac cycle. Usually occurs in the ejection phase, and it is ranges from 110 to 130 mmHg. Diastolic blood pressure is the minimum pressure, or we can say that it is the resting pressure, which is around 60 to 80 mmHg. This is simply due to the blood in the vessel, and we can say that diastolic blood pressure is an indicative of peripheral resistance, and systolic blood pressure is an indicative of stroke volume. And pulse pressure is the difference between systolic blood pressure and diastolic blood pressure, and usually it varies around 40 mmHg, considering 120 minus 80. So pulse pressure indicates the stroke volume, how much of blood is ejected, and also it indicates the compliance of the heart. And mean arterial pressure, usually a mean means average. So mean arterial pressure is not simply SBP plus DBP by 2. Why? Because the duration of systole and diastole are not same. Systole will be around 0.3 and diastole will be around 0.5. So there is a 0.5 seconds. So there is a gap difference in the time duration. So we are not taking like that. Actually, if you are taking that 0.8 seconds, if it is counted for every 0.1 second and by 8, that is the mean arterial pressure. That can be derived with another formula called as diastolic blood pressure plus 1/3 pulse pressure. And coming to the factors affecting BP. So blood pressure can be explained as cardiac output into peripheral resistance. So we already know what is cardiac output. Cardiac output is stroke volume into heart rate. So just ignoring this heart rate, if we take about stroke volume and peripheral resistance. So what are the factors that affect stroke volume? So one is preload, contractility of the heart, and afterload. Preload is nothing but venous return and is dependent on so many factors: blood volume, to venous tone of the vessel, venous pressure gradient, all these will be. And coming to the next entity is the contractility of the heart. More the contraction of the heart, more will be the stroke volume. Similarly, more will be the systolic blood pressure. And afterload is the load against which the heart has to work. Usually afterload is indicative of diastolic blood pressure or the resting blood pressure. And peripheral resistance, as we mentioned, peripheral resistance is the resistance at the level of arterioles. So arterioles have very good smooth muscles, so they can constrict and dilate. So diameter of the blood vessel and viscosity of the blood vessel. So viscosity of the blood itself causes a resistance, and the peripheral resistance is indicative of diastolic blood pressure. If the peripheral resistance is more, diastolic blood pressure will be more. And heart rate, we know that sympathetic nervous system stimulates the heart rate, and diastolic parasympathetic decreases the heart rate. So the same factors, we make them as central factors and peripheral factors. If we take the central factor like cardiac output, which is dependent on stroke volume, so which is systolic blood pressure. So cardiac output is more means systolic blood pressure is more. And we already know the cardiac output factors: stroke volume into heart rate. And to get the details of this cardiac output, just follow the link above, which is a link to the video of cardiac output. Here, simply remember that cardiac output is directly proportional to systolic blood pressure. And coming to the peripheral factors, including the peripheral resistance and afterload. We'll see what is there. Peripheral resistance. So I already mentioned peripheral resistance is nothing but diastolic blood pressure. So directly proportional to diastolic blood pressure. And this peripheral resistance depends on two factors we already mentioned: diameter, viscosity, even velocity of blood also. We'll see that. Blood volume. So more the blood volume, more the stroke volume, more the systolic blood pressure. So that's a direct relation. Venous return, simple. More the venous return, more the stroke volume, because of Frank-Starling's law, more filling of heart, more the stretch of the heart. So similarly, more the systolic blood pressure. So what relation? Directly proportional. Coming to the elasticity of the blood vessel. Elasticity of the blood vessel is whenever blood is pushed by the heart, it creates a pressure, and if the blood vessel is elastic, the pressure is accommodated. If the blood pressure is not elastic, pressure rises. So inversely, less elastic, more rise in BP, such as seen in atherosclerosis, which is seen in old aged patients. Velocity of blood flow. So more the velocity, the resistance increases, so diastolic blood pressure increases. Diameter of the blood vessel. More the diameter, less the peripheral resistance, less the deep BP. Viscosity of the blood. More the viscosity, more the peripheral resistance, more the deep BP. So directly. So whatever the factors that are inversely related are only two factors. One is the elasticity of blood vessel, one is diameter of the blood vessel. Less diameter, more DBP, more diameter, less DBP. And elasticity. More the elasticity, less the change in pressure, so less the BP. Less elasticity, less accommodation of the volume of blood, so more blood pressure. And coming to the regulation of blood pressure. Regulation of blood pressure occurs within seconds, minutes, hours. So within seconds, we call that as short-term regulation. Usually it is neural. And within minutes, there is an intermediate regulation. And within hours, it is a long-term regulation. So there are three kinds: short-term, intermediate, long-term. We'll see. Short-term regulation within seconds or minutes. One is baroreceptor, two is Bainbridge reflex, three chemoreceptor mechanism, four cerebral ischemic response. And intermediate within minutes to hours, renin-angiotensin vasoconstrictor up to angiotensin, not including the aldosterone, because secretion of aldosterone takes some time. So renin-angiotensin system. And stress relaxation and capillary fluid shift. These are the three intermediate regulations. And long term is with renal. So renal body fluid mechanism, that is called regulation of ECF, and aldosterone mechanism. This occurs within hours to days. And other than these three, we can say that there are hormonal mechanism and local vasoconstrictor and dilators local mechanism. So this is the baroreceptor mechanism. The receptors for baroreceptor mechanism or baroreceptors, they are located in carotid sinus and aortic arch. So the receptors are stretch receptors located in carotid sinus and aortic arch. And if you look at here, carried by 9th and 10th. So afferent is glossopharyngeal 9, vagus 10. Now the center is in medulla, which is vasomotor center, and it contains the following components: nuclear tractus solitarius, vasodilator area, vasoconstrictor area. So nucleus tractus solitarius is considered as a sensory area. It receives the information, and whenever it is stimulated, it inhibits the sympathetic tone, that is vasoconstrictor area, and it stimulates the vasodilator area, that is parasympathetic tone. Efferents are through vagus and sympathetic nerves of thoracic segment. And effector is two. One is heart, two is blood vessel. So explaining this baroreceptor mechanism, follow this flow chart. Let us think that there is increased blood pressure. Okay, so BP is increased means baroreceptors are activated. So whenever the baroreceptors are activated, the discharge through 9th and 10th is increased. What is the sensory area of vasomotor center? Nucleus, tractus, solitarius. Then what happens? It stimulates parasympathetic. And inhibits the vasoconstrictor area. So simple, parasympathetic is activated means heart rate is reduced, and sympathetic is inhibited means vasodilatation plus decrease in myocardial contractility. So inhibition of sympathetic outflow, so decreased myocardial contractility and vasodilatation. All these factors together will cause decreased blood pressure. So increased, the final result is decreased, and it comes to normal. This is a negative feedback loop. So this is how our baroreceptor mechanism acts when BP is increased. Reverse. Blood pressure is decreased, no more activation of carotid sinus, no more stimulation of nucleus tractus solitarius. So vagus is inhibited, and whenever anti-S is not activated, vasomotor center is activated. So sympathetic tone is increased, myocardial contractility, vasoconstriction, increased cardiac output, here increased heart rate. So the final effect is increased BP. So the reverse mechanism. And baroreceptors are such a receptors which can undergo resetting. Usually they work within a mean arterial pressure range of 60 to 180 mmHg. If it is less than 60 or above 180 mmHg, baroreceptor mechanism can't bring back the BP to normal. So if the BP is elevated for a longer duration, this baroreceptor set point is reset to the newer higher values. So the baros is reset. So it tries to keep the BP elevated. And if the BP is lowered by any medication or physiological response, this baroreceptor is again reset to the normal value. So reset is also reversible. Coming to the Bainbridge reflex. So whenever the venous return or the blood volume is more, the stretch of the atrium occurs. So I can say simply the load on the heart is more, it is stretched, it has to simply empty the contents out. So the afferents will go to the medulla, sympathetic tone is increased, heart rate and contractility are increased. So heart rate and contractility are increased means BP is increased. Chemoreceptor mechanism. There are two chemoreceptors, peripheral and central. We'll talk about this peripheral, which are located at the aortic body and carotid body. So whenever the levels of oxygen is low, or H plus is more, or carbon dioxide is elevated, or BP is lowered less than 80, mean arterial pressure less than 80. 80 to 160 is baro, less than 80 is chemoreceptor. Then activation of chemoreceptors, that activates the vasomotor center directly. So vasoconstriction, tachycardia, force of contraction increases. All these factors increases. The final result is increased BP. So whenever the BP falls in less than 80 mmHg, or the chemical factors like carbon dioxide is elevated, or H plus elevated, or oxygen is lowered, our chemoreceptor mechanism will get on, rises the BP. And there is a response called as cerebral ischemic response or Cushing's reflex. So whenever the blood flow to the brain is reduced, when it occurs when the BP is lowered less than 60 mmHg, or there is a rise in intracranial pressure occluding the blood flow. So vasomotor center blood flow is reduced. Now direct activation of vasomotor center due to hypoxia and hypercapnia due to decreased blood flow. Then intense stimulation of vasomotor center causes intense vasoconstriction. So all the vessels almost contracts, the mean arterial pressure almost rises to 200 mmHg, and compensatorily whenever the pressure is raised, baroreceptor reflex is activated and there is reflex bradycardia. So increased blood pressure with reflex bradycardia is seen in Cushing's reflex or cerebral ischemic response. And also activation of cerebral cortex area 13 increases the BP, and hypothalamus anterior is similar to parasympathetic, causes decrease in BP, or posterior similar to sympathetic, causes increase in BP. And during inspiration, due to the leakage of information from the respiratory centers, there occurs fall in BP. Then intermediate mechanism. We already know renin-angiotensin mechanism. So whenever the BP is lowered, the kidney thinks that the blood volume is low. So it tries to conserve it by releasing a substance from macula densa which is activated and activates the JG cells to release renin. Whenever the renin is released, it converts angiotensinogen to angiotensin 1. It is converted into angiotensin 2 by angiotensin converting enzyme which is present in the lung. So whenever this angiotensin 2 is on, it is the active form, it causes vasoconstriction, and also with the help of aldosterone, renal retention of salt and water. But our concern here is up to this mechanism, vasoconstriction, and that causes rise in blood pressure. So decreased, and the final thing is increased. Similarly, it prevents the fall in BP. And capillary fluid shift. So whenever the blood pressure is more in the vessel, at the capillary end, due to the increased hydrostatic pressure, the blood leaks into the spaces, or the plasma leaks into the spaces, decreasing the circulatory blood volume. So increased hydrostatic pressure, fluid escapes from capillaries into the spaces, so circulating blood volume is lowered, that causes decreased BP. And if the blood pressure is low, fluid shifts reversely, that is called reverse capillary fluid shift. And stress relaxation, whenever the pressure is raised, the blood vessel stretches and that accommodates the pressure, and this causes fall in blood pressure. So these are the intermediate mechanisms. And coming to the long-term regulatory mechanism, the important long-term regulatory mechanism which has infinity feedback gain. So it can correct the error to 0. So it has an infinity feedback gain. So what is that? ECF volume regulation is whenever BP is raised BP causes increased hydrostatic pressure in the renal blood flow. So increased filtration, that also causes diuresis and natriuresis. So decreased blood volume. So finally BP is lowered. So initial change is increased and the final change is decreased blood pressure. So this is the ECF volume regulation. And the other factor is renin-angiotensin. The final thing is aldosterone mechanism. So whenever the BP is lowered or extracellular sodium is lowered or ECF volume is lowered, renin-angiotensin system is activated. That causes aldosterone synthesis, and aldosterone causes sodium and water retention. So increased blood volume, so increased BP. And also it increases thirst mechanism, so increased intake of water, increased circulatory blood volume. So both will cause increase in BP, which restores the BP. So this is renin-angiotensin aldosterone mechanism. And coming to the hormonal mechanisms, so let us enlist the hormones which increases the BP. Adrenaline is a vasoconstrictor. So vasoconstrictor increases the peripheral resistance and increases the DBP. Thyroxine has a direct stimulatory effect over the heart, so increased myocardial contractility. Vasopressin is also a vasoconstrictor as well as water reabsorber, so circulatory volume increases. Serotonin is a vasoconstrictor, so increases the BP. Coming to the hormones which decrease the BP. Arterial natriuretic peptide, which causes natriuresis. So nothing but the diuresis, which decreases the blood pressure because circulatory blood volume is reduced. Histamine is a dilator, bradykinin is a dilator, acetylcholine is a dilator. All these cause decrease in blood pressure. And the local mechanism, local vasoconstrictors like endothelins, which cause vasoconstriction, they also affect the BP, and local vasodilators. So vasodilators of metabolic origin. So if vasodilatation occurs, the peripheral resistance is lowered there, so DBP is lowered there. So carbon dioxide, lactate, hydrogen, adenosine. These are all vasodilators of metabolic origin. So increased metabolism, more carbon dioxide, more lactate production, more H plus production, and more ATP is broken, adenosine is produced. And vasodilators of endothelial origin are nitric oxide, which is of endothelial origin, which causes vasodilatation. So these are the local mechanisms which alters the BP. And thank you for your patient listening. So summarizing that, what is BP? It is a lateral pressure exerted by the column of blood on the vessel wall. Then what are the factors affecting BP? BP is equal to cardiac output into peripheral resistance. So what are the factors that affect cardiac output and what are the factors that affect peripheral resistance? And coming to the regulation, neural or short-term regulation, baroreceptor mechanism, brain bridge mechanism, cerebral ischemic response, and Cushing's reflex. And intermediate, renin-angiotensin mechanism, stress relaxation, capillary fluid shift. And long-term, renal regulation of ECF and aldosterone mechanism. And we have hormonal mechanism, which are vasoconstrictors and vasodilators. And we have local mechanisms, which are endothelins of local origin and dilators of nitric oxide and carbon dioxide, H plus, lactate, adenosine, which are dilators of metabolic origin. So this is the summary of BP regulation. Hope you understand well. Thank you. Bye.